I'm going to start myself. I should introduce myself. I'm Daria Bacher-Lattimore. I'm the president of the National Alliance, or NAHEWD, and I'm also the PI and director of the Northeast Caribbean AIDS Education and Training Center. So I'm going to give you a little background on NAHEWD and how this series developed, and then I'm going to turn it over to our speakers. So NAHEWD is a membership organization of the 8 regional and 2 national AETCs. And we support the AETC program mission. It was established in 2010, and we support the AETC's mission, the component of the HRSA-funded Ryan White AIDS program, which has an explicit directive to build and maintain a well-educated and culturally sensitive health professions workforce that can provide prevention, diagnosis, care, and treatment and medical management for people at risk for and living with HIV. NAHU collaborates with multiple organizations in order to promote and educate on the work of the AETC program. Since 2018, we have been funded by the American Academy of Addiction Psychiatry as a partner of the Opioid Response Network to address the intersection of HIV and opioid use disorder. ORM was created to support efforts in addressing the prevention, treatment, and recovery of opioid use disorder. They provide free resources and technical assistance locally in communities across the United States and its territories. So please visit the ORM website for more information or to submit a request for technical assistance. Today's program is accredited, and there will be post-evaluation surveys will be emailed to you after the webinar, and you should complete them within the 2 weeks to make sure you get the credit that you deserve. There will also be a link in the chat at the end of the session that you can directly go to for the evaluation. Then your certificate will be emailed to you within 2 weeks after you complete the evaluation. So as always, it's up to you, your responsibility to verify the requirements with your state licensing board. So that's, without further ado, I am going to turn it over to our colleagues from the Greater Lawrence Family Health Center. See, and they are going to share on their efforts to integrate care for people living with HIV and substance use disorder. We asked them to present on what their successes have been, their challenges, and their lessons learned. So I'm going to turn it over to you, Amy and Chris. Thank you.
Hi. Good afternoon. My name is Amy Bositis. Before I kick us off, I just want to make sure, can you see my screen appropriately and you can hear me? Okay, great. So as I said, my name is Amy. I am a nurse midwife by training, but have been providing program support as a program director at Greater Lawrence Family Health Center for the last 6 years. And what that means is overseeing our Ryan White HIV program, our viral hepatitis, our substance use program, our homeless program, and our prevention program. And so I've had the joy of living and working with all of these diseases and conditions for the last 6 years, and am excited to share with you sort of some of the experiences we've had, and hopefully hear from you about some of your thoughts. I will let Chris introduce himself, and then I will kick us off.
Thanks, Amy. And thank you, Daria and Liz, for inviting us to speak this afternoon and share a little bit about what we learned and what we continue to learn as we do this work on the ground. My name is Chris Bositis. I'm a family physician and an HIV specialist by training. I currently am the clinical director at the National Clinician Consultation Center at UCSF. But I continue my clinical practice at Greater Lawrence Family Health Center in Lawrence. Before joining the NCCC, I was the clinical program director of the HIV and viral hepatitis programs in Lawrence as well. And so have been very intimately involved in a lot of the programmatic changes and integrations that we're going to talk to you today about.
Just want to acknowledge that that Sandra Silva will not be able to join us today. She is definitely our third wheel in implementing all of these programs and really helped with the leadership of it, but is not able to join us. So we will be covering her material. All right. So my slides are not progressing. There we go. Just first want to state that we do not have any disclosures to report. What we're hoping to go over with you today first is to describe the model that Greater Lawrence used in integrating substance use and infectious disease care. We will also identify some of the benefits that we have experienced and see and believe in integrating this care, and then talk a lot about our challenges and some of the successes, but how we've approached some of these challenges. To give you a roadmap of where we'll be going, I will kick us off with understanding the background of Lawrence, of a really significant HIV outbreak that took place in our community, and then talk about our response to that. If those of you, many of you may have already heard this, this talked about by Chris earlier in the summer. So I won't spend all of our time talking about what we did, but I will try to identify some of the key points. And then Chris will take it over as he discusses successes, challenges, some of the particular lessons we learned, and some of the best practices that we think are worth sharing. And then we're going to open it up. We would love to hear your questions, discussions, and hear from others of you who are doing similar work. All right. I realize many of us are from different places around the country, so I just want to help identify where we are. So Lawrence is a relatively small community in northeast Massachusetts. We are 30 miles north of Boston. We do not identify ourselves as sort of being a highway city, but as you look at this map, you can see that we are actually tucked in between 93 and 95, which I think is actually a very important understanding of where we are, because in my next slide, I will share with you that we were really sort of on the forefront of the introduction of fentanyl fentanyl was introduced into our drug stream a lot earlier than it was in many other communities within the Commonwealth. And we think some of that is because of where we are located, that it is easy to get from Boston up into New Hampshire or from Maine down to DC. So we're sort of at a crossroads. So this was a slide that was made for us by CDC as they looked back on the fatalities from opioid overdoses between 2012 and 2016. We really wished we had made this ourselves or been looking at it in this format earlier. Because you can see, just to orient you to this top dotted line is our neighboring city called Lowell. We are the sort of smaller dotted line, the W, and this darker one is in Massachusetts and Boston. So, you know, as early as about 2013, the city of Lawrence, and even earlier for Lowell, began, our overdose rate started to exceed the state's and exceed Boston's. We knew we had a significant opioid issue at this point. I don't know that we were tracking this quite as closely. But unfortunately, as we look back, we were able to identify that probably somewhere around 2012, 2013, fentanyl was introduced into our drug supply, and perhaps and most likely became the most dominant form of opioids that our community was using. As the CDC did some investigation, I think we have a couple of ideas why. First, I think is as the map shows, we're sort of located in a transportation hub almost. We also believe we started to manufacture fentanyl in our communities, and so and because it offers such a really high, a lot of our clients became easily addicted to fentanyl. So just want to point out that as early as 2012, probably around 2013, the opioid epidemic in our community became a really significant problem for our community members, and it began to, our community health center began to really expand our treatment of substance use. We have a program funded in part through the Department of Public Health. It's called the OBOT program. It's a real nurse case management coordinated program where we treat opioid use disorder in our clinic with buprenorphine and Vivitrol.
Amy, can I interject real quickly?
Absolutely. Mm-hmm.
Sorry. And one point that I really want to make sure that we make here is that we do believe that it was this early introduction of fentanyl into the drug supply that was a significant driver of a lot of the future events that impact the health and well-being of our community that we will soon be talking about. So again, this is a critical piece to understand in the history of how things unfolded in Lawrence.
Right. So perhaps one of the most significant things that changed in Lawrence was that in 2016, our Ryan White program, kind of in conjunction with our outreach and prevention program, identified 3 newly diagnosed individuals, newly diagnosed with HIV, from a very different population than we were sort of used to serving. They were all injection drug users and were also all homeless. And 3 doesn't seem like a big number, but when our average yearly rate is about 15, 3 felt like a bit of a change. And so we began to investigate and pay attention. And I will say 2 out of these 3 were actually acutely infected with HIV. So as we started to investigate and listen and ask questions, we reached out to the Department of Public Health to ask for their help and their guidance. And they were amazing partners in this. We responded quickly and efficiently and really helped guide us as we began to ask more questions and investigate. What came of it is that they actually invited the CDC to come to Lawrence and to Lowell and to conduct an EpiAid where they did interviews, qualitative and quantitative data analysis, looked at some of did a molecular analysis of individuals' HIV and were able to identify that this was in fact a very significant HIV outbreak in our 2 communities between 2016 and 2018, and that it was primarily driven by the early introduction of fentanyl into our drug stream. So just want to briefly talk about what the CDC was able to help us understand, because I think it will help you understand how we responded. So during these 2 years, they were able to identify 129 individuals who had been newly diagnosed with HIV, who met their case definition. About 88% of them identified injection drug use as their primary risk factor for HIV. And again, they were able to identify fentanyl as the primary drug that clients were looking for and were using. And those of you who know fentanyl, and at this point I would assume most of us have a lot of experience with it, but if you don't, there's a slightly different pattern of use with fentanyl. So I had a number of clients state that they would use somewhere between 10 and 20 times a day, which just allows for more access to sharing and the potential then for infectious diseases. Fentanyl was also, as we understand it, was potentially made here, which means that it was actually relatively cheap. And in fact, in Lawrence, it was much cheaper than it was in Lowell, and much cheaper than in Boston. Our clients also reported, however, a relatively high sexual risk factors for contracting HIV, and often did not use condoms with their primary partners because of the trusting relationship. Another interesting find was that 100% of these individuals also identified homelessness within the last year. These individuals had been homeless. I think the best way that we can understand this is that the degree of their substance use was so high that many of them had been driven from their homes and from their community. And then lastly, 90% of them had lab evidence of hepatitis C. And so we were starting to understand what was going on in our community as being a lot bigger than we originally thought. Not only were there new diagnoses of HIV and a raging opioid use epidemic in our community, but we now also needed to look at homelessness and the social determinants of health that accompany homelessness, and also viral hepatitis and chronic hep C. So now we get to kind of what did we do? And I think this this messy Venn diagram, I hope will kind of give you a picture of the way we started to integrate and rethink our different programs as a health center. And I should pause and just state, I haven't said much about who we are as a health center. Greater Lawrence, and this is what all the acronyms are, Greater Lawrence Family Health Center is, I believe, the second largest community health center in Massachusetts. We provide care to, I believe, about 60,000 community members. So it's a pretty robust community health center. It is a family practice model, has a residency associated with it. And we have been funded by Ryan White since the 90s and funded a lot through the Department of Public Health to do prevention work and to do substance use care. So we've had a lot of programs for many years, but like probably most places, we have all worked in silos for quite a long time. But this HIV outbreak and the guidance of the CDC really helped us rethink what we were doing and how we were doing it. We know we needed to enhance the development of many of our programs, but we also just understood that we actually needed to integrate our programs differently. And when I say programs, I think about patient care. We wanted to integrate care so that a patient could come to one place and receive all of the care they needed. We needed the programs to be integrated, and we needed our staff to be cross-trained and integrated into one program rather than into many different programs. So you can see all of the many different sort of programs and activities that Greater Lawrence was providing, and really the opioid epidemic was sort of driving all of them and bringing all of these programs together. We will talk through a little bit of kind of how we did this. So I want to highlight a couple of our new and our slightly more innovative programs to give you an idea. Our flagship program is our mobile van, which was funded, and we started in about 2016, and we were providing primary care to those primarily who were homeless on this mobile van in 2016. But around 2018, we introduced substance use treatment onto that van. And we brought buprenorphine and started to treat individuals with opiate use disorder with bup. And at the exact same time, also began treating those with HIV and viral hepatitis. And it was a little bit more staggered. We really started with bup because that is what our patients most wanted. But as we began to develop those relationships, we started to identify those who had HIV and viral hep and initiate them on HIV treatment and or PrEP if they were not HIV positive. And then, a few months later, we're able to introduce the treatment of hepatitis C for these individuals. And so this program continues to this day. We continually make modifications to it, where we bring our mobile van, who's on the mobile van, how we provide care. We're always kind of changing it depending on where our patients are and what they need. But this is sort of the clearest example of how we have brought substance use care and infectious disease care and integrated it so a patient can receive in one visit primary care, substance use care, HIV care, and possibly even hep C care in one visit by one provider and in a location that is suitable for them. We also recognize that a lot of our patients and clients had quite a lot of experience with the House of Corrections and were often in and out of our local House of Corrections. And so over time, we have had about 4 different programs working with them. We continue to adapt depending on where the needs are. We provide testing within our local jail. We have at times linked up with those who have HIV or hep C and tried to sort of form relationships with them so that when they were released, we would have them ready to go into treatment. We provide overdose education within our jail. And right now we actually are working with those who are released, particularly those who are Black or brown in our community and male, and making sure that the minute they're released, we are there to help walk them back mostly into the medical world, but sort of linking them back into care. So we continue to adjust and adapt, but always recognizing that this is a key player in our patients' lives. We've also recognized that our local hospital plays a really significant role for our patients, but also just for patients' care. It's kind of in a sense of continuity. So we have a couple of different programs that are based at our local hospital. One is the Bridge Clinic, which is not actually a clinic, it really should be called a bridge service. So those individuals who show up to the ED or are admitted who want to start on any kind of substance use treatment, we are able to start them there. So it could be buprenorphine or methadone, start them there, and then we will sort of bridge them to outpatient treatment and follow them until they are settled into an outpatient program. We also have had an addiction consult service, and we'll be starting that back up again, and provided just amazing addiction consults to individuals who were in the hospital. And we also have a mostly resident-driven HIV consult. So anybody who is in the hospital who is also diagnosed with HIV can be started on medications while they are inpatient, and then likewise bridged into outpatient care for their HIV. And I will say it is the close relationship with our hospital-based program that helped us identify quite a few of these, particularly those who are acutely infected with HIV. And frequently when we cannot find a patient for a period of time, it will be the hospital who will say, oh, so-and-so has come back, they're being treated for endocarditis or some complication, and we will be able to go there and reinitiate treatment with them. At this point in time, we are not able to offer all FDA-approved medications for opioid use disorder, and so we have to collaborate with our local methadone provider. We have in many different ways. We will often go there to do HIV and STI testing. We also refer patients very easily and efficiently into methadone if they choose that as their treatment option. We are also looking to hopefully provide methadone ourselves at some point soon. And then lastly, we work very closely with our local law enforcement, primarily on responding to individuals who have overdosed. But I believe in the last month, we have linked 2 individuals onto buprenorphine after having visited them in their home with I don't know the police were with us that time, but the police had given us their names as to people who had overdosed. And so again, it's not necessarily HIV specific, but the individuals who are doing this are very much aware of the risk for infectious diseases that accompanies opioid use disorder.
Amy, can I jump in and add one other thing, which I'm not quite sure how we forgot to include on this slide. One of the very first programs that we developed in response to the HIV outbreak that we were experiencing in Lawrence was our
SSP. Absolutely.
So we now run a syringe service program that's based at in the community at a Greater Lawrence community-based site that also provides STI testing and screening, as well as overdose education and naloxone distribution. So all of those services are actually combined in one at one of our community-based sites, which is in an area that is fairly centrally located within the city, so that many of the individuals that historically have been experiencing homelessness can easily access it and get all of the services that they need there at that site. So
yes, thank you. Our relationship with our SSP is sort of our secret sauce, and the success of the mobile program is often dependent upon our SSP. So thank you. So my last slide.
Sorry, Amy, there's a question. It says, it sounds like there's a relationship with the local police department. Do they provide you with information about people who may be high risk in lieu of making an arrest and taking someone to jail?
They do, in fact. Yes, we've actually started something called the Hub, which has now really grown, and it's very different than what it started as. But yes, the police will reach out to us or to members of the Hub. They have actually started to recognize that substance use is a chronic illness, and they are shifting from seeing it just as a criminal matter. and will ask us to intervene first. And perhaps if we can get somebody linked to care, they would prefer that than taking somebody, than arresting them. And we've actually have one of the police officers will actually drive somebody to detox instead of arresting them. So yes, indeed. So my last slide before I turn it over to Chris is to talk about what I sort of see as our values, because although these programs, we'll talk a little bit about the sort of specifics of the programs, but I think what really makes them significant is sort of the values that we hold with them, and that as we redesigned our care, we had a couple of things in mind. First of all, we were identifying that these are some of our most vulnerable community members. And because of that, we wanted to bring care to them. We did not want to ask them to come to us in our buildings where we were in control, where there were waiting rooms and long lines and children and people who might judge them. So we were going to step out of our comfort zone and bring care to our patients. Secondly, we try to provide the lowest barrier, we provide care with the lowest amount of barriers possible. So we try to jump through the hoops and not ask our patients to do that. So for instance, we really try to work hard to make sure that the insurance process is easy, that they don't have to go anywhere to get tests. I don't know that I explained this earlier on, but with our mobile buprenorphine program, we actually bring buprenorphine to them if they are going to initiate Suboxone. We would have a bonded courier drive the medication to them and not ask them to go to the pharmacy. And we also adopted a real harm reduction approach to substance use care pretty early on, and recognizing that connection and engagement was sometimes the goal that we were most interested in. And that is if we could maintain a relationship with an individual, it was their path to recovery, and that we were there to support them and not require sobriety in order to be in our programs. All right, so with that, I'm going to turn it over to Chris to talk a little bit about some of the successes and challenges, and I can move your slides for you if you want.
All right, thank you. So yeah, we're going to start with successes and challenges, and then we're going to go from that into some of the lessons learned and maybe a little bit more of the detail, the programmatic details that would be helpful for people who are looking to either start or sustain or improve upon similar services that they may already be providing in their community. So again, you know, when we first noticed the uptick in HIV diagnoses within the community, we recognized that we were having a hard time engaging many of the people with a new HIV diagnosis in care for their HIV. As you can see, prior to July 2018, just about a third of individuals who were newly infected with HIV and had a substance use disorder and were also experiencing housing instability were actually engaged in care. And so, as Amy mentioned, one of the most important interventions that we developed to address this particular challenge was the mobile buprenorphine clinic. And that clinic is, as she said, a mobile van that goes to various places throughout the city of Lawrence, and actually in one of the neighboring communities, Haverhill as well. But one of the key places that it parks is actually in the parking lot of our community-based center that I referred to earlier, which is where our syringe service program is housed. When we first started the program, again, the aim was really to engage more individuals who were living with HIV and substance use disorder concurrently, but we did not limit it to people who were HIV infected. It was open to anybody who wanted treatment for their substance use disorder, and even people who didn't have substance use disorder, who just were having a hard time accessing care in the community, will come onto the mobile health unit from time to time. But one of the big success stories of this mobile health unit is that since we started in the summer of 2018, we have initiated over 200 individuals on buprenorphine treatment through the mobile health unit. Now, I will say that not every single one of those individuals has maintained on buprenorphine. Some of them have been lost to follow-up. Some of them have transitioned to methadone. Others have actually transitioned from the mobile health unit to our brick and mortar sites as they've achieved more stability over time. And we've seen all of those things have happened. With regards to individuals who were HIV infected, as I mentioned earlier, this was a key target population that we wanted to try to address. You can see here that as a result of the mobile health unit, we went from an engagement rate of 38% prior to starting the MHU to 81% of individuals with HIV, substance use disorder, and housing instability being engaged in care by the winter of 2019, right before COVID started. All of those individuals were so yeah, 100% of individuals with HIV who were being seen on the mobile health unit were receiving ART, and we were able to document a viral suppression rate of 66%, which was a huge improvement. And more, equally importantly, almost over 3/4 of individuals who were receiving treatment on the van for their HIV were also getting treatment for their substance use disorder. You can see that over time, those numbers have not been sustained. COVID really has been a huge challenge, and we'll talk about that a little bit more in one of our future slides. But we're slowly starting to build back, where we have seen a slight increase in engagement over the last year and a half. We've been able to maintain a lot of people on their treatment for their HIV. Viral suppression is still not quite as high as we would like it to see, although we would like it to be, but I will add to that even though the last data point that we have suggests that just over half of the individuals that we're serving through this program with HIV are virologically suppressed, that's largely because we don't have data for many of them. So most of them are getting their ART and they're on their ART, but they have not all been had a recent viral load so that we can say that they're virologically suppressed. And many of them remain on their treatment for their substance use disorder. For individuals who are not HIV infected, we have worked really hard to integrate pre-exposure prophylaxis, education, and care into the visits on the mobile health unit. The most recent data that we have for pre-exposure prophylaxis care indicate that just about half of the individuals that we had seen who were not HIV infected on the mobile health unit had been offered pre-exposure prophylaxis, and just over 10% actually started on pre-exposure prophylaxis, which is a huge, it might sound like a relatively small percentage, but I will tell you that I just reviewed there was just a meta-analysis that was published looking at the PrEP care cascade in the United States. And in that meta-analysis, the highest percentage of individuals that were started on PrEP in any program that was published as of when that meta-analysis was done in 2020 was 3%. So 11% is actually a really a substantial improvement. Maintaining people on pre-exposure prophylaxis has been challenging. Again, the last data point that we have suggests that only 3% of those who are initially started on pre-exposure prophylaxis are still active on their PrEP. Okay, next slide, please. Some of the other success stories that we would highlight include our ability to link care both on the inpatient and outpatient side more effectively. So for HIV specifically, we have had a number of new diagnoses that we were able to start on antiretroviral therapy, many even as they were still in the hospital, as a result of our relationships with the care management teams and specifically the Bridge team that was working with individuals with substance use disorder in the hospital. From a viral hepatitis perspective, one of the probably the biggest success stories that we're now offering treatment to individuals who are chronically infected with hepatitis C on the mobile health unit. And in an effort to facilitate that and expedite that, we were able to secure through a generous grant from the Department of Public Health in the state of Massachusetts a mobile transient elastography machine so that we can do accurate fibrosis staging before starting individuals who are chronically infected with hepatitis C on their treatment. And one of the nurse practitioners who is part of the Healthcare for the Homeless care team working on the mobile health unit was trained to also provide hepatitis C care. Another success from the substance use disorder perspective is that we are receiving weekly calls from local houses of corrections for referrals for individuals who need to either start or continue on their treatment for substance use disorder after their release. And then overarching all of this is that fundamental idea of care integration. And speaking to the success of that, we had 4 nurses who were cross-trained in HIV, viral hepatitis, and substance use disorder care coordination and case management. And so they really were able to get to know individuals in all of these different, who were part of all of these different programs and make sure that they were connected to the right care at the right time. Amy already talked a little bit about the hub, which was a community-based program that brought together members of law enforcement, the clinic, and then other community-based organizations dealing with some of the higher risk individuals living in the community to figure out what services they needed to help reduce their risk of fatal overdose and other complications of their substance use disorder. All right, next slide, please. Not advancing. Okay, there we go. Sorry about the technological difficulties, folks. As everyone in the audience, I'm sure, is experiencing, COVID has really dealt a huge whammy to our ability to effectively carry out many of these programs. Many of the staff that we trained across these different programs who were critical to the care integration were deployed to provide COVID testing, COVID case tracking, and other COVID-related services. And as a result of the pause in in-person care that occurred by necessity during COVID, we lost track of many of our most vulnerable because their phones were no longer active. We didn't know where they went. I think another challenge that we recognized and that was highlighted as well as a result of COVID is that interdependent systems are really only as strong as the weakest link. As an example of that, I can tell you that one of the major drivers of the success of our mobile health unit when we first started was the relationship that the folks who were working in our SSP were able to build with people who were coming in and obtaining needles and other supplies from that SSP program. And through those relationships, they were able to identify different stages of readiness in those same individuals for seeking treatment for their substance use disorder. And so the vast majority of our referrals for MOUD care came from our SSP program, but because the SSP is still operating, but it's what we call stationary, which is kind of like the waiting area where people would hang out and have coffee while they were getting their needles and works. That essentially has closed down. People come in, they get their supplies, and they leave. And so we haven't been able to build, our staff have not been able to build those relationships over time the same way they had done previously. Another challenge to care integration that we would highlight is that the multiple different reporting requirements that we have across the different grants that fund these programs is a real burden to both staff and the people that we're serving in the community. Last, but definitely not least, I would say that the understanding of harm reduction, balancing the goals of harm reduction with a sincere desire to see people be well and in complete recovery is often that creates a lot of tension for our staff, and it has led to burnout and frustration. I think we as the leadership have had to kind of consistently provide reminders about the success stories that we've experienced, and remember the goals and principles behind harm reduction that are driving all of our care decisions on a daily basis. So in terms of lessons learned, and I realize that we're actually kind of going a little bit over time here. Some of the key, so I'm gonna go through these relatively quickly. From a clinical perspective, there are two key lessons that I would say that I have learned as a clinician. One is don't overpromise, and what I mean by that, and that relates to patients, to other clinical staff, and to our support staff as well. I think we need to be careful and understand that we can't always provide everything to everyone at all times. There are going to be times when we are limited and cannot give people exactly what they need or what they want. And I think it's important to recognize that so that we can work together to figure out, okay, when we're not able to provide all of the services that we want to be able to provide in the moment, what are the workarounds? How can we figure out other ways to get individuals the care, the support that they need to help them on the road to recovery? Not all clinicians are going to be comfortable providing all aspects of integrated care, and so we don't want them to feel like, we don't want them to burn out because they're feeling like they are pressured into doing something that they are not comfortable doing. And failure is a part of success. We have had at least one person that we know of that we had started on pre-exposure prophylaxis in the mobile health setting become HIV infected, so that was, in my mind, a real lesson to be learned. Similarly, a number of the patients that we've started on treatment for their hepatitis C have not completed it, or they've just been lost to follow-up, and so we're not even sure exactly what happened to them. But at the same time, I think that each time we see, each time we experience a failure, we are trying to learn from that so that we can better serve the next person who comes in seeking care with us. In terms of operational lessons learned, the value of community relationships and community buy-in cannot be underestimated. And so in order for our programs to fly successfully on the ground, we need to make sure that we're building those relationships ahead of time, even before they're launched, as much as possible. We've also recognized that multiple funding streams can make programs flexible, but they also can make them very complex. As an example, the aforementioned reporting requirements. It takes a village for all of these things to come together and to work well. Clinical pharmacy being on board, operations, the clinical team, the community. And then a really important lesson that we've learned is that the leadership and buy-in from, the vision and buy-in from our leadership team has been really critical to our success in terms of our capacity to integrate care across all these different domains. Programmatically, we would say that it's really important to make sure that the team is on board and that they share the vision that you share for integrated care, and making sure that all of these different programs are running the way that you want them to run. We also would recognize that supporting staff as they learn the new science and new ways of thinking and have to take on new responsibilities is really key to success. And the flip side of that is, for some people, balancing more than one of these different areas may actually be difficult or challenging, and we have to be sensitive to that, and we have to be able to pivot and say, you know what, it's okay. You don't have to do all of these things all at the same time, all the time, if you are burning out as a result. In terms of some of the best practices that we would highlight, Amy mentioned the bonded courier that we developed early on for bringing buprenorphine to the different mobile locations, particularly when we were doing observed inductions. I will say that we're not doing very many observed inductions anymore, because most of the people that we're starting on treatment with buprenorphine nowadays actually have some experience already with buprenorphine. So that's less of an issue, although it does still happen from time to time. We've developed integrated meetings across different teams to review some of the higher risk individuals that we're caring for in these different programs. I think the integrated leadership structure, so having the leadership composition of each of these different programs be made up of a lot of the same people has been really, really critical to the success of our programs. I would give a shout out to the transient elastography again. It has really facilitated our ability to stage people with in terms of their fibrosis before we start them on treatment for their hepatitis C. It has really opened up doors for treating hepatitis C. And then I would also add, and this is probably, again, one of those really key things that got us started with all of this to begin with, that treatment for opioid use disorder has really been a critical tool for increased engagement in both HIV and hepatitis C prevention, care, and treatment. And then in terms of sustainability, what we think are some of the key factors to keep this going over time, leveraging multiple funding streams. And in order to do that, we have also recognize the importance of building thoughtful relationships with some of the key stakeholders, such as law enforcement, the Department of Public Health, and other key funders, providing ongoing education and training for staff, and recognizing when people are starting to burn out and not pushing them beyond what they're able to give. Similarly, for the clinicians, providing them with mentorship, training, and support to make sure that they feel well equipped to provide all the different types of care that we're asking them to provide in this setting, and maximizing third-party payment. This gets back to the finances. We're fortunate that we do have a fair amount of funding to support this work, but at the same time, we have leveraged the reimbursement that we get for the clinical services that we provide to keep things going. And we already talked a little bit about the importance of the leadership support of the vision. So I will stop there and open it up for further questions and discussion.
I think we have one question in the Q&A. And I think this was when you were talking about the involvement of law enforcement. And so they were asking at some point, can you elaborate on how that law enforcement cultural shift actually occurred?
Yeah, I can start that. We can't, first of all, take credit for all of it. I will say that it really began within the law enforcement themselves. But I think one piece that we were able to play was that as the law enforcement were bringing forward individuals that had overdosed, I think we did two particular things. One was that we showed compassion to the individual and asked to sort of be responsible for them, that we would reach out and take care of them, not take care of them, but would provide services for them. And then the second thing is that without being really oppositional, we tried to slowly change the language that was being used for individuals. And, you know, healthcare uses very different language than the law enforcement do, but particularly around substance use. And so we continuously said substance use rather than addict, or individual with substance use rather than addict. And so I think slowly over time, by helping to change language and by also showing our commitment and compassion towards individuals with substance use, I think that the work that they were already doing themselves probably just accelerated.
Yeah, and I mean, I think the other key point to that is there was one person in particular within the Lawrence Police Department who was essentially a champion for this work. You know, I think once that was identified, things were able to grow and develop from there. So having a champion that you can identify within the police department is really critical.
Fabulous. We had one question in the chat regarding HCV treatment and whether you require use of specialty pharmacy to distribute the meds, and if so, how do you work around this barrier?
We sure do. We feel your pain.
Yeah, it's the insurance companies that require the use of specialty pharmacies. But Amy, you can speak to how our care management team so expertly ensures that even people who are unstably housed get the medications delivered to where they need to be.
Absolutely. So what we have done in all of our programs have assigned nurses and community health workers to work with these individuals to provide case management and care coordination. And the primary role of the nurse in the Hep C program is to work on these, this issue. And it's not easy. And we are in the process of constantly learning and changing our approach to it, but essentially it is the responsibility of the nurse to follow up with the specialty pharmacy. We have multiple phone numbers we call, we track constantly over and over again. And then we will often call the patient when we can reach them, and then call the specialty pharmacy on the same line and try to facilitate that. It's not easy. We are really working to try to change this system, but we are in the same boat as the rest of you all, in that we just try to do the work, as much of the work as possible for the patient, recognizing that we can't do all of it.
We have another question. When do you project your work will return to the successes of prior to COVID?
That's a great question. There's kind of two big pieces to it that we're working on. One is reopening our SSP fully. And so we have reopened, but again, those relationships will take time to rebuild and to shift. Our clients actually really like getting their works from the window. It's like a drive-by window, and they can keep on going. And so, really kind of enticing them back into having relationships and conversations with us. So that's one. And then secondly, we have embedded an HIV case manager within the syringe service program. And that case manager provided unbelievable case management to this population that we're talking about. And she has transitioned to a different program. So we need to rehire her and we have actually. But it's back to relationships and keeping those staff working closely with those clients.
I actually have a question too, because you referenced a couple of times in the presentation when you're talking, about harm reduction and then about sustainability, about how important it is to make sure the team is on board with integrated care and the harm reduction principles. And I'm wondering, and also making sure they're not burning out. So is there a way that you have institutionalized it? Do you have regular check-ins with staff, or how have you approached that in your clinic?
So to kind of address burnout in particular, we do part of Ryan White programs and actually DPH programs. We provide clinical supervision to all of our staff at least once a month. And the clinician they're seeing right now is just very, very successful at helping them work through client issues and staffing issues. As a leadership team, we are also taking the temperature of our team every single month and identifying people who are struggling. And we'll try to either adapt their workload or provide one-on-one care and support. We will also, particularly when somebody passes away, we will remember that person as a team, but we will also sometimes gather ourselves and get together and tell stories of their life. So that's kind of how we take care of our team. Harm reduction was we have a slightly maybe different story with that. As particularly, I'm thinking of our staff who have been working in substance use for a long time, and sort of the substance use programs used to be pretty strict. And so if you were getting buprenorphine for opioid use disorder, you had 3 strikes, and if you were not taking your bup, you were discharged from the program. Whereas now we generally maintain a client in our program and continue, rather than to push them away, we try to bring them closer and see them more often, have more visits, do more outreaches. And that was actually a real change, particularly for our substance use nurses and staff. And so that has just taken time. And as we review cases and as we review literature and as other people are talking about harm reduction, I think some of our team is feeling more and more comfortable providing harm reduction. Chris, do you have any thoughts on harm reduction?
I think just what you said, and reminding people of the principles. I think another important issue to acknowledge that we have started to, but need to continue to work on, is that historically, harm reduction has been a white response to the opioid epidemic. Back when the drug epidemic predominantly impacted communities, Black and Brown communities, the approach in the United States was not a harm reduction approach, it was a criminalization approach. And now that it has shifted to also impact the white community, our staff see, oh gosh, how come all of a sudden we're taking this harm reduction approach before, now, when everybody, when so many of our patients are white, when before we just locked people up in jail when they were Black and Brown. And that is a historical fact that we need to reckon with and we need to acknowledge. And I think that we want to ensure that we are applying harm reduction principles equally to everyone who is suffering from substance use disorder. But that's something that we're working on as well.
Thank you. I see we're at the top of the hour, and if folks want to, and if you have time to answer the final two questions. Okay.
Yeah, so one of the questions is about the PrEP care cascade meta-analysis, and I can't figure out how to type it in the box. It is published online in AIDS and Behavior in 2021. I'm sorry, I can't type it in.
Well, we can send that out
I
to
can put it in the chat.
after.
I can put it in the chat.
Okay, great.
Yeah.
And further, are you documenting the implementation of your integration efforts?
It's a great question. No, we're telling you.
That's future AIDS and behavior.
Documenting like in a publication kind of thing, or documenting, we have presented some of our data, particularly we presented at ASAM, the Addiction Med Society's conference in 2018, 2019, like a year after we were running. So we presented our data on treatment, access to treatment for MOU for substance use disorder and PrEP, but not the HIV hepatitis stuff yet.
And I know this is a rather could have a rather in-depth answer to this one question, but it was about your perceptions of injectable PrEP and what do you think that impact is going to be on adherence and retention?
I think that's a great question. And I don't know that we have the answer to that. There are a lot of concerns about the use of injectable PrEP, but there are a lot of potential advantages as well. And I think combining injectable PrEP with injectable Suboxone is a very potentially attractive treatment for individuals who are having trouble with taking medications every day, not because they don't want to, but because they can't keep it, they get stolen. The chaos of their life, they lose it because it's swept up in, as when law enforcement comes in and takes down their tents. So I think there are some real advantages to using injectables for both substance use disorder and pre-exposure prophylaxis. And we haven't yet figured out how to operationalize that.
Well, thank you very much for this very robust discussion and a fabulous presentation. And thank you all for hanging through this, even though we went on for an extra few minutes. And thanks, Eric. I see you posted the link for the article in the chat for us. So again, if you want to get your continuing education credits and or give us feedback, please fill out the evaluation. The link is in the chat and we will be emailing you that as well. Again, thank you to the presenters and thank you to all for attending. Have a great weekend.
Thank you so much, everyone.
Thank you.